Welcome to Shift Report, the podcast brought to you by EMcentric.com. EMcentric is the go-to information and resources hub designed exclusively for the emergency medicine community. On each episode of Shift Report, we host key leaders from the field who share their insights and experience from inside the world of emergency medicine. Our goal is to inform you, to encourage you to use what you learn to improve your practice and to improve yourself. Today, we welcome Dr. James Phillips. Dr. Phillips practices in Washington, D.C. He received a medical degree from the University of Oklahoma and trained in emergency medicine at the University of Illinois at Chicago, along with completing a fellowship in disaster management and emergency management at Harvard. Today, he'll focus on disaster planning post-COVID while sharing some insights on how he manages the hectic mix of clinical and non-clinical roles we all know so well. Welcome, James. Thank you for taking the time to share some insights with us today.
Hey, thanks for having me, Dr. Jolly. I'm excited to be part of this inaugural podcast for EMcentric. I think there's so much potential here, and I'm looking forward to being a part of your circle here.
Thank you. Like many of our listeners, you have a wide range of experience in emergency medicine. Your background includes a fairly remarkable mix of disaster management experience and leadership in the U.S. and around the world. What are some key areas you've been focusing on in the last few years?
Yeah, that's an interesting question. So I've taken the standpoint in my career that I wanted that my career should focus around dinner party stories, and the more stories I can rack up in my list of things to talk about at a dinner party, the better my career. And so I've taken a lot of interesting opportunities and sort of taken a tortuous path through my medical training and the things I've been able to accomplish. You know, the focus of my career is on disaster medicine. Right now, I'm currently serving as the chair of disaster medicine for the American College of Emergency Physicians. I am the chief of disaster medicine and operational medicine for George Washington University, where I currently work. I've been around the world and trained and worked in interesting places, from the Ukraine to Nepal following the earthquakes, to the Middle East. And so it's exciting to look back on my career and see some of the interesting things that I've accomplished, but more importantly, the things that I've learned along the way from the different people and particularly the physicians that I've encountered along the way.
That's great. We've all, developed the dinner party stories during our careers. Let's go back to the beginning. What led you to emergency medicine?
So when I was a little kid, circa let's call it 1983, I was about 5 years old when my asthma started to get real. And if I could go back and tell my parents that having two smokers in the house, a cat, a dog, and shag carpeting was probably not the best thing for your little wheezy kid. So I was in the emergency department all the time, getting nebulizer treatments and chest x-rays. And what I learned at a very early age, I have a 5-year-old son now, is that I could go into the emergency department with this terrible feeling, and there was an antidote, there was a cure, there was a way to make me feel better. And then I would go home feeling normal. And I latched onto that. I wanted to be that person that could do that for other people. So actually being an emergency physician with two brief detours is the only thing I've ever wanted to do since I was 5 years old.
That's great. We all had people we looked up to along the way. Who were a couple of your key mentors along the way, and what did they leave you with?
So I think that, I think back to like my childhood physicians and things like that inspired me. There was a plastic surgeon that I worked for and with when I was in college, when I was a burn tech in the ICU at the Baptist Burn Center, a doctor named Juan Brew. I remember him because he's the first person who ever took me to the operating room, and probably the reason why I ended up detouring into a surgical residency for a few years before coming back. My ultimate influence on my life undoubtedly was actually my father. And I know most people can probably say that about their lives, but my dad was a career firefighter and the first firefighter in the building as a rescuer following the Oklahoma City bombing in 1995 when I was a junior in high school. And that's what inspired me to join this fledgling crew of disaster medicine trainees in the 2000s. My fellowship director, Gregory Ciatone, he's the director of the Disaster Medicine Fellowship Program at Beth Israel Deaconess in Boston. He's the one that sort of started me on the pathway to learning about disaster medicine, conceptualizing future threats, and how to turn that into actionable work. And so those would probably be the primary people that inspired me along my pathway, along with a number of world events that pushed me towards where I am right now.
You mentioned world events, and we've all been through a big one over the last few years since the beginning of 2020, or frankly, the end of 2019. COVID brought public health disasters to the forefront. From an emergency medicine perspective, what are the key lessons that our community, the emergency medicine community, should take from COVID?
You know, the lens that I look at this through right now is different than what it was during the heat of the pandemic. You know, I was fortunate enough from a public health standpoint to be an educator on the topic to a lot of people. You know, I as a disaster medicine specialist, you know, we focus on a number of different ways in which people get hurt and injured, and pandemics being one of them. And when the pandemic initially arose, I had an amazing opportunity to be able to lecture and then to actually work for CNN as a medical analyst, where I was able to perform, you know, small feats of public health education every single day, both in studio and eventually when the studio is closed and doing it from home. But now when we look back on it, we reflect, we do our sort of after action report, as we call it, and try to analyze what is it that we missed, what is it that we could have done better. And what really grinds my gears right now, if you don't mind my Family Guy reference, is that I feel like we've all forgotten that even though I saw 5 patients with COVID this week in the emergency department, we've forgotten that, number one, that COVID happened, or we're trying to forget. But even more worrisome is that we forget that the next one's coming. I think that people don't realize, maybe you know, our memories are short when we think about pandemics and epidemics and disease outbreaks, and just how much we've experienced that over the last 2 decades. And I say that because I'm really worried that the next one, which is coming, is going to have a different response than it should, similar to what parts of COVID did. You know, when just in my short career alone, we've seen a near miss on a massive epidemic, a massive pandemic, which was the swine flu outbreak, the H1N1 outbreak in 2009. That one was particularly terrifying to me as a let's see, I was a 4th-year resident in plastic surgery at the University of Michigan, and we were seeing young firefighters and pregnant women on ECMO. The entire ICU was filled with people on ventilators from the swine flu. And we got really lucky that that did not turn into something the size of COVID. The mortality rate was astronomical. A few years later, 3 years later in 2012 is when we first started to hear about the MERS coronavirus, the Middle East Respiratory Syndrome. Certainly the size of that and the ongoing nature of that is larger than what we hear about in the news. But my time in Saudi Arabia has taught me that that is still a real issue. But that was a coronavirus that really didn't get the press because it didn't, I guess, hurt enough people. But then only 2 years later, right, we saw the West African Ebola outbreak in 2014, and how close we came to seeing that turn into a worldwide true pandemic. I mean, we had disease transmission in the United States of Ebola, and that was a wake-up call to hospitals. I've never seen preparation like we did in 2014, 2015. Even in 2 years after that, we were still thinking about Ebola, preparing our emergency departments, developing our contingency plans. And then 5 years later, we have this novel coronavirus out of China. So if you think about that, you look at the math of that, it's every 3 to 5 years, we're experiencing a new serious viral pandemic. So if we think that this one is over, and we are very lucky in that COVID has turned in to basically a bad upper respiratory virus, let's hope it stays that way. But 5 years from now, history is showing us that we're going to be right back at this, whether it's a novel influenza virus, whether it's Nipah virus, whether it's an engineered virus, it's coming. And what I'm terrified about is that the key lesson is that we're forgetting what we've just gone through. I don't fault people for that. We want to forget what we just went through. But from a policy standpoint, a planning standpoint, we can't.
Fascinating perspective. So what have you seen happen to the practice of emergency medicine as a result of COVID? And there are lots of ways to go with this discussion, but what have you seen in how it's happened in the emergency departments and to emergency medicine?
This is a similarly pessimistic viewpoint for where I am right now. I think that COVID-19 was devastating to emergency medicine. I think that a lot of physicians were required to be very involved. We from critical care, pulmonology, pathology, and certainly emergency medicine. I feel like we took the brunt of what was going on during this pandemic. And simply from a morale standpoint, from a burnout is the term that you hear a lot, which I think is really just a succession of moral injury, that I think that the general morale of emergency medicine has taken a major hit. I hope to see it recovering as we transition out of the phase of the lower respiratory COVID into this upper respiratory COVID, and I hope that it recovers. But I think that it was really hard for me as an emergency physician, particularly because I was very public with my opinions and things like that, doing TV and Twitter and whatnot. I saw this very unexpected decline in trust and belief in science by the general public. And to see other colleagues of mine that were also not telling the truth or fighting what was like established science, that was very difficult for me personally. And I know for some of my colleagues at work that we speak about, or that we've spoken about the topic. I think that that the politicization of medicine really hurt people, and I think it hurt emergency medicine. And while that's a difficult metric, it's a difficult thing to measure. There is a metric by which we can see whether or not emergency medicine is a good place to work, and that's in the medical school match. And if we look at what happened in the match over the last 5 years, it's very clear. Emergency medicine has always been, a top 5, top 10 specialty, attracting top medical students into it. But really, in the years leading up to COVID, leading up to 2019, the match rates were incredible. The number of open positions in emergency medicine were in the single digits for a couple of years. That's incredible. And then 2019 happened, and we survived the pandemic, those 2 years. And then we look at the 2023 match, where we had over 500 open positions following the initial match in emergency medicine. And while some of that can be attributed to an increase in the number of available positions, there's no question that established and well-respected programs didn't fill their classes with medical students. And we are the light at the end of the tunnel, or some bright spot there, is that this year's match was better. The number of unfilled spots was, I think, under 200. And then those ultimately get filled, after the match is over. But to see such an incredible decline from single-digit open spots to more than 500 is a clear metric that shows that COVID-19 is the one major thing that really hurt emergency medicine. And I sure hope that it recovers. You look at the surveys that are done by the American College of Emergency Physicians, the AMA, different groups to survey physicians in general about their rates of burnout, their decisions as to whether or not they want to continue in their career, or are you exploring things outside your standard practice? And emergency medicine is at the top of every single one of those. It's multifactorial. It's not just the pandemic, but certainly I don't think that the pandemic was good for emergency medicine. I think there's a lot of things that we can learn from it, and ways that we can change things in the future to make it a better specialty. But as of right now, man, I think we're kind of a nadir in terms of popularity of emergency medicine as a specialty.
Another important perspective, and you're a leader locally and nationally and internationally in disaster planning. So, for the emergency medicine community, sort of a combination of questions. What do you feel are the key focus areas for disaster planning, and what keeps you up at night?
Yeah, I love that question. So, disaster medicine is a budding specialty within emergency medicine. We've heard recent good news moving forward that it appears that if all the dominoes fall in the right way, we will be the next board certified subspecialty in medicine. We've been working for that for several years, and everything's going in the right direction there. What we need to be doing so as disaster medicine specialists, what we look at is we look at how do we prepare and respond at multiple levels, not just our own individual emergency department, but within healthcare coalitions, within our communities, within our states. How do cities and states respond and prepare? How does the nation prepare for larger events like this? Think of things like massive earthquakes, terrible hurricanes, things of that nature. And then what we've all recently been through is understanding that major disasters truly are international. But one of the catchphrases for disaster medicine is that all disasters are local. What we recognize is the need for expertise. What we need is state and federal elected officials to rely on experts. They do that in all sorts of other fields. We need that reliance to improve, because that took a real hit in COVID-19 with all the dirty, gross politics that got involved with medicine. And there's certainly still aspects of medicine where politics is really harming things. But what we need are elected officials who will listen to medical experts so that we can prepare, mitigate, respond, and recover from these things correctly. And as in all things in the United States, that requires money and it requires work hours. What we do in emergency or in disaster medicine and in emergency management in general, particularly in healthcare, is that we have a process by which we do this. We do what we call, in various different forms, a hazard vulnerability analysis, where the first step in recognizing that you have issues that need to be dealt with is to identify what the hazards are. What are the hazards that are unique to your jurisdiction? Again, whether that's your emergency department or the nation. Identify the main hazards, and there's metrics by which you can do that to determine what are the things where you need to be the most worried. And then identify what your major vulnerabilities are. You have hazards, but have you prepared for them sufficiently? If you're worried about a tornado, do you have a storm shelter? If yes, then you're maybe not as vulnerable as you are to other things. So identifying your hazards and your vulnerabilities at all these different levels is that first step. And that's what allows you to take your limited resources, which again is that money and those work hours, to try to achieve the goal of whatever is your top number one hazard, your number two, your number three, using your resources to work against those things, to lower those on your list, so that when you come back next year, that hazard isn't as high on the list anymore. That's the main concept of disaster planning. The disasters that deserve the most attention locally and nationally right now are not the sexiest ones. It's not a nuclear detonation. It's not suicide bombers. It's not the dirty bomb releasing, cesium in New York City. Those things are high impact, but they're very low risk. They're very low. The rate of them is very low. But what we really need to be looking at are the real hazards that we are all vulnerable to, which, as any American can tell you right now, are mass shootings, vehicular ramming attacks against crowds, cyber attacks in healthcare, and as we've been discussing today, the next pandemic.
Good points there, and a very good realistic perspective of what we need to prepare for. So turning to the public a bit, you have significant experience attempting to educate the public during a crisis and before crises. What do you want the public to know about preparing for the next crisis?
Great question. A crisis is a very broad term. Let me try to break it down in terms of what I think we need to be preparing about for disasters. And as a physician, everybody thinks of disasters in different ways. So let's establish what is a disaster first. A disaster is when you have, in medicine, you have patient needs that outweigh the available resources. And so think of an emergency department. So I was in Boston during the Boston Marathon bombing. I had just started my fellowship. And so you imagine what happened when those two bombs detonated at the finish line of the Boston Marathon, where you had, over 100 patients with shrapnel wounds, traumatic amputations, and all sorts of other issues that were going on. And they had to be transported to emergency departments. Well, each of those places only has a limited number of rooms, a limited number of nurses, a limited number of doctors and supplies. And so being able to conceptualize things in terms of resources and needs is the primary thing about disaster medicine. When we analyze what our hazards are that we need to prepare for, the primary thing that we as American citizens need to think about is how to improve those resources. And that takes money. And that takes tax dollars. And it takes elected officials who believe in science, believe in the truth that scientists talk about, that will earmark those dollars towards preventing, hopefully, but certainly mitigating against and improving the response to the next crisis. When we think about that in terms of infectious diseases, there's two major areas, well, really three, where we worry about that in terms of infectious diseases. The first one is disease surveillance. That's looking for the next virus, the next outbreak. That's not chastising international viral surveillance and CDC programs. It's augmenting them and helping them to establish surveillance programs that can detect these viruses early, so that we're able to prepare and hopefully mitigate against them. When you think about things in terms of, and this is more rare, this is 10 or 20 years down the road, when we're thinking about synthetic biology, and we're thinking about the ability for people in their home labs or otherwise to generate new organisms that can harm us. If you read the scary stuff that most of us read about, you think about the fact that you can get the genome for smallpox online, and if you have sufficient equipment and ability, eventually someone's going to be able to potentially do that. Those things worry me. That if you ask me about what keeps me up at night, that's part of it. And then the trifecta of that, the third part is antimicrobial resistance. So when we're looking at things, not just bacteria that are resistant to antibiotics, but Candida albicans, we're looking at fungal infections that are resistant. All of these things can turn into major problems for us. And so in terms of what I think the public needs to realize is that when you're watching the news and you're hearing things about bills that aren't being passed, or bills that are they're being passed, but the funding is reduced to the CDC and to the Health and Human Services Department, those things matter. Those things put us at a higher risk of missing the next virus until it's too late, missing the next antimicrobial resistant organism, or failing to stop a synthetic biology experiment that goes rogue and causes a major problem.
That's really great information related to large-scale disaster planning and the sorts of things that those of us who are interested in this field think about to try to protect the public. Let's step away from disasters and back to sort of the day-to-day practice of emergency medicine, which you also do. Emergency medicine faces challenges, which you've mentioned. What do you want the public to know about the challenges facing emergency medicine when they seek emergency care, or their loved ones seek emergency care, or they depend on our services?
Well, I think emergency medicine is the most critical part of medicine in America. We are the experts at unplanned medical care. We pride ourselves on being the experts in the emergencies that involve every other specialty. We want to be the experts in knowing what can go wrong. And while we may not be the endocrinologist, we need to know how to manage the endocrinology emergency. We may not be the surgeon, but we know how to manage and identify the postoperative complications. When it comes to emergency medicine, I think that we are extremely valuable, and having celebrated our 50th anniversary as a specialty recently, I think it's interesting It would be interesting for the general public to understand how young we are. Ask your grandpa what he did whenever he had an emergency. And when he went to the hospital, there was no ER, there was no emergency specialist to take care of him. And so, what I think is most pressing right now, particularly post-COVID, is that we need patients to have patience and to be understanding that right now the healthcare system, particularly in emergency medicine, in most places are kind of in dire straits when it comes to the workforce. People will look back for decades on the great nursing shortage of 2021, the mass exodus of nurses that left the workforce following COVID. And while a lot of physicians left as well, we are crippled a lot of the times in emergency departments in getting patients out of the waiting room where they're sick and they're hurting and they're desperate and they need care. We don't have the room to bring you back. We need people to understand that just because there's an empty bed doesn't mean there's a nurse to manage that bed and manage that patient. And without nurses and without an influx of new nurses into the system, we're going to be stuck in this situation for a while where patients are in waiting rooms for not just 2 hours, not just 4 hours, but I've seen patients waiting for 12 hours to come back to get a broken bone treated, to get infection treated with antibiotics, to get a medication refill, things of that nature. And oftentimes, and very understandably, people are very upset about that. People pay money into their insurance program, they pay into Medicare and Medicaid, and they expect to be taken care of. But at times we're handcuffed by the shortage of staff that we have available to take care of people. When there's not enough nursing staff upstairs to manage inpatients, those people who are admitted instead are boarding in the emergency department. And I know most people that have listened to this have heard about the boarding crisis. And, there's been times in the emergency department where 75% of my beds have been unavailable because there's an admitted patient in that bed, meaning I only have 25% of my space to take care of all the people in the waiting room. And so I would say that to the public, when you visit the emergency department, and we want you to come if you have an emergency, understand that we're doing our best. And until it's going to take, a few years, I think, really, realistically, before the nursing shortage improves and we're able to get patient flow back to where we want it and where patients deserve it to be.
You bring up some very important points, and I think in future iterations of our podcast, we'll have you and panels of others from around the country talking in depth about how to solve that problem and hopefully bring those solutions to decision makers who can help with that. Coming back to our colleagues in emergency medicine, and broadly defined as nurses, nurse practitioners, PAs, residents, and physicians who are critical to the care of patients in the emergency department, we're practicing in a tough environment. And we have for a long time, but perhaps it's gotten tougher. From your practice perspective, what advice can you give to emergency providers about taking care of themselves in the environment that we've chosen?
All I can give is the advice. I don't know if I'm in a position to advise other physicians because I think I'm hurting just as much as every other doctor. I think that our personal health and our mental health are the most important things that we can be focusing on right now. So many people that I work with, and including myself, we're burned out. We don't necessarily enjoy going to work every day. We don't necessarily get the same joy that we used to when we first signed up for this job as undergraduates. So desperate. We worked so hard to get into medical school, right? And it's weird to look back 25 years and see sort of where we are now, where the anxiety of getting ready to go and do a shift, and am I going to be able to provide the care that I want to? And if I'm not able to, are patients going to be upset with me? Am I going to be a victim of violence at work? And am I just going to become continually depressed and more anxious about this being my career? I think that there continues to be a stigma against anxiety and depression in America for all people. I think that's improving. But in American healthcare, there remains a stigma that as a doctor, you're not allowed to be anxious or depressed. You fill out paperwork when you take a new job that says, that negatively asks you if you've been treated for behavioral health or mental health issues recently, and that can somehow negatively affect you. And I think that collectively, as physicians, but most importantly as emergency physicians, which in my opinion is the most social of medical specialties, we've really got to work on taking care of each other within our medical groups and within our societies. I think we need to get back to, socializing and really being friends with our colleagues, because as we all know, it's our colleagues that pull us through the tough times and help us enjoy the good times. So if I was able to give any advice, and it's the advice I try to give myself every day, it's to try to find that joy in your job again. Try to find the joy in the day-to-day medicine, and really try to make plans and experience that those fun times with your colleagues that we all really used to enjoy pre-pandemic. And I think we'll get back to that again. So take care of yourself. That's the main advice I would give to my emergency colleagues.
I think you're clearly in a position to give advice, and that's wonderful advice for all of our listeners. I want to thank you for joining us in this installment of our EMcentric podcast series, and special thanks to Dr. James Phillips for sharing his important insights. For more content, networking, and innovation in the world of emergency medicine, please visit us at EMcentric.com. Thank you, Dr. Phillips.
Thanks for having me.